All right, we got everyone here. Why don't we kick off? So welcome everyone to another edition of Tumor Talk. This is the collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Neurosurgery, where we bring on authors of recently published articles in the Journal of Neuro-Oncology. And we talk about kind of their rationale for their study, their results, and the clinical relevance really of everything that they published. So we are pleased today to have our group, Michael Chan, Claire Lanier. Is it Lanier or Lanier?
Lanier.
Lanier, okay.
Thanks for coming
and Jane
along.
Pierce.
Yeah, thanks for having
why don't you
me.
guys go ahead and introduce
No, no
yourselves and we'll
worries.
kick it right off. You guys
It's a good
jump
time.
right in.
I like getting to meet everyone and
Sure. So I'm
Always
Claire
learn a ton.
Lanier, and I'm a PGY3 resident at Wake Forest
Let's
School
see.
of Medicine
We've
in
got
Winston.
Claire
North Carolina.
and Jane are both here. I'm going to bring them in.
I'm Jane Pierce. I'm a fourth-year medical student at Wake Forest in North Carolina.
And Michael Chan, I'm a professor of radiation oncology at Wake, specializing in CNS malignancies.
Hi.
Hey guys, how you
you're
doing?
muted. Good.
Sorry, I said if you want to go ahead and share
welcome
your
to
screen.
Tumor Talk.
This
Yeah.
is a it's fairly informal.
give us
as you can
a-
tell already probably, but
We'll do
you know,
one more
we
minute.
encourage
I believe
discussion and
Jason
kind of
is not
interaction through
able
the
to
audience
make
as
it due to
well.
a scheduling issue. He emailed about.
This is being broadcast on our new platform,
look right?
Cassini, which is kind of amazing,
Perfect.
right? Number one,
Okay.
you guys get this DOI number, which is awesome.
So
because it basically acts like a
essentially,
publication.
my
which is
paper
great. But number
or
two,
our paper is on
a lot of our
long-term
viewers now can
survivors
subscribe
of
so that it's
stereotactic
synchronous and asynchronous
radiosurgery for
watching.
brain
So people choose to tune in
metastases.
live or they just
And so
watch
we
at a
asked
later time.
ourselves, is there
which
something
is,
special about this
convenient,
population?
and expands viewership
Do
without a
brain
doubt.
metastases or brain failures reach a
That's
plateau?
great. Thank you.
And
so
are there any
much for the
factors
invitation.
associated with
No
something
worries. And
called
who's going to
a
be
brain
sharing your
metastasis
slides?
velocity of 0
Um,
that we
I
define
will-
for the first time in the literature? Should I just share my screen?
You can wait a minute.
So
It's okay.
I think the most important thing,
So let's see.
to set the
Wait
stage
to the 401
is
mark.
that I'm happy to be here talking about long-term survivors of brain metastases. I think historically they've not had a great outlook, and I think with advances in
I'll do a brief intro and then we'll
radiation,
we'll kick it off.
stereotactic radiosurgery, surgeries, systemic therapies, we're at a time point where we're asking ourselves, we need to look at this heterogeneous group of people and see how best to move forward with their treatment and follow-up. So we had those clinical questions in mind. And so just for some background, and terms of the patients that we treat with stereotactic radiosurgery here at Wake Forest,
We got everyone
our
here. Why don't we kick
standard
off?
follow-up
So welcome everyone to another
is
edition
an
of Tumor
MRI
Talk.
6
This is
to
the
8
collaborative
weeks
effort
after
between
initial
the Journal of
SRS,
Neuro-Oncology
and then
and
we
Lenox Hill
space it out to
Neurosurgery,
Q3
where we bring
months
on authors of
2
recently
years,
published
and then
articles
only
in the Journal of
after
Neuro-Oncology.
at
And we
year
talk
3
about
would we
kind
move
of their
to
rationale
every
for their study,
4,
their results,
and
and
then
the
years
clinical
4 to
relevance
5 we
really
might move
of
to every
everything
6
that they
months.
published. So we are pleased today
And
to
I
have
think the reason
our
we're
group, Michael
hesitant
Chan,
to spread this out
Claire
further is that
Lanier. Is it
we
Lanier
have
or
data
Lanier?
that patients have better
Lanier,
outcomes
okay, and
if
Jane
their
Pierce.
brain
And why
metastases
don't you
or
guys go ahead and
recurrences
introduce
in brain
yourselves and we'll kick it right
metastases are
off. You guys can
identified
jump right in.
asymptomatically rather than symptomatically.
Sure.
So
In
I'm
fact,
Claire
they're more
Lanier,
likely
and
to
I'm
die
a
of their brain
PGY3 resident
metastases
at
if
Wake
they're
Forest School
identified
of
from
Medicine in
symptoms.
Winston. And so
North
that's an
Carolina.
incentive to catch these lesions before they become
I'm Jane
symptomatic.
Pierce. I'm a fourth-year medical student at Wake Forest in North Carolina.
So here actually at Wake Forest,
And,
one
Michael
of
Chan, I'm
Dr. Chan's
professor of
colleagues and one of my
radiation oncology
attendings,
at
Dr.
Wake,
Michael Ferris,
specializing
defined brain
in
metastasis
CNS malignancies.
velocity, which is the total number of brain metastases after initial SRS divided
you're
by the
muted.
time elapsed since that initial
Sorry,
SRS.
I said if you want to go ahead and share your screen.
And that's
This
important
is
because
it's
it's
fairly
actually a
informal, as you can
prognostic
tell already,
metric,
probably,
a
but
biomarker.
we encourage discussion
And it has
and kind of
been
interaction through the audience as well.
validated in multi-institutional studies, according to McTire in 2020,
Perfect.
and Yamamoto looked at also
So
confirmed the validity, and this was in
my paper or
Japanese
our paper is on
institutions. So,
long-term survivors
around
of
the world,
stereotactic radiosurgery for
multi-institutional
brain
throughout
metastases.
North America.
And so we asked
It's been
ourselves,
validated
is there
to
something
predict
special
for
about this
survival
population?
and recurrence
do
and
brain
neurologic
metastases
death.
or brain failures reach a
So
plateau?
just to put
and
a
are there any
plug, it
factors
is
associated
against a
with something
validated
called a brain metastasis
calculation, and
velocity
you
of
can find it
0
on MD
that we
Calc
define
for
if you
the
want to
first
use
time
it?
in the literature. And so it can be continually
I think
recalculated over
The most
time.
important thing
And
to set the
we're
stage
actually even looking
is
into
that I'm
folks that
happy
might
to be
have
here
an
talking
initial
about
low
long-term
brain survivors of
metastasis
brain
velocity,
metastases,
and then
I think
it becomes a
historically
higher
they've
brain
not had a great
metastasis
outlook, and I
velocity, and
think with
perhaps what could
advances
change
and
what's changing in that population.
radiation,
So
stereotactic radiosurgery,
many future directions for
surgeries,
this.
systemic
And
therapies.
so we do know
we're
that
at a
in
time point
patients with
where we're
a
asking
BMV
ourselves,
over
we need to
4
look at this
versus under 4,
heterogeneous group
they
of
have a
people
twofold
and see how best to
risk
move
of dying
forward
of
with their
neurologic
treatment and
death.
follow-up.
And also
So
7
we
fold
had
more
those
likely,
clinical questions in
now in
mind.
the immunotherapy era.
And so just for some background and terms of the patients that we
So,
treat with stereotactic
we are
radiosurgery
already
here at Wake
using it
Forest,
here in terms of
our
the clinical
standard
decisions we're
follow-up
making. The brain
is an
metastasis
MRI 6 to
velocity.
8
So for
weeks
those
after
under
initial
4,
SRS,
we repeat
and then we space it out to
stereotactic
Q3
radiosurgery
months
for a
2
BMV,
years, and then only
between 4 and
after
13, we think
at
about
year 3 would
either
we move
repeat
to every
SRS
4,
or a
and then
clinical
years
trial
4 to
that
5
I'll
we might move to
share
every
with you in a
6
second.
months. And if you have a BMV over
And
13,
I think the
that's when we
reason we're
start to
hesitant
consider
to
whole
spread
brain.
this out any farther is that we have data that patients have better
And so,
outcomes if their brain
applications
metastases
of
or
BMV,
recurrences
so
in
this
brain
is a study where
metastases
we're
are
actually looking
identified
specifically at
asymptomatically
someone's
rather than
brain metastasis
symptomatically.
velocity.
In
and
fact, they're
then,
more likely to die of their brain
randomizing them to
metastases if
different
they're
treatments.
identified from symptoms. So you can
And
get
so that's an
randomized
incentive to catch
these
SRS,
lesions before they become symptomatic.
plus hippocampal avoidant whole brain.
So
Here actually at Wake Forest,
SRS
one of
alone.
Dr. Chan's colleagues, and one
Dr.
of my
Chan, I
attendings,
know
Dr. Michael
you-
Ferris,
This is your
defined brain
trial. Is there anything
metastasis
in particular
velocity,
you wanted
which
to
is
share
the
about
total
it?
number of brain metastases
No, I
after
think that
initial
that was a really good
SRS
summary.
divided by the
you know,
time
this is
elapsed since
the
that
first
initial
study
SRS.
looking
And
at
that's important
what's the
because
right
it's
thing to do
actually
in
a
the salvage
prognostic
setting after
metric, a
SRS has failed.
biomarker.
And so, you know, anybody
And
out there
it has
watching,
been
please open the study
validated
and enroll patients.
in multi-institutional studies,
Right.
according to McTire in
So,
2020. And
why we did this
Yamamoto
present
looked
study
at
on the
also
long-term
confirmed the
survivors.
validity, and this was
So we wanted to assess their
Japanese
outcomes.
institutions.
Like I
So,
mentioned, is there some sort of
around the
plateau?
world,
What should
multi-institutional
the follow-up
throughout
be?
North America.
And we also wanted
It's
to
been
define
validated
its
to
population of a
predict
BMV
survival
of 0
and
So you
recurrence
defined
and
a
neurologic death.
BMV, but never a BMV of 0.
So just to
And
put a
the
plug,
reason
it
we
is
asked this
against
is
a
because
validated
it's different calculation, and you can
with
find it on MD Calc
patients
if you want to use
who
it. Have no brain metastases, but died 2 months
And
after
so it can
initial
be
SRS,
continually
are very
recalculated
different
over
than
time.
a patient who never
and,
has a recurrence.
we're
and
actually
lives
even
for
looking
3
into
or 4
folks
years.
that might have an initial
So we wanted
low
a way
brain
to define
metastasis
that.
velocity, and then it becomes a higher brain metastasis
And
velocity, and perhaps what could change, what's changing in that
slide
population.
in, my
So
apologies,
lots of
but
many
a
future
BMV of
directions
0
for
is
this.
someone who has
And
not
so
had a
we do know
recurrence
that
within
in
2
patients with
years
a
after their
over
initial
4
SRS
versus
under 4, they have a twofold more likely
And so
risk of dying of
on
neurologic
multivariate
death.
analysis,
And
what
also
predicted for
7
BMV of 0,
fold more likely.
we found 2 things that
now
were
in the
significantly
immunotherapy
associated
era.
with that: a BMV of 0 or no recurrence.
So
within 2 years.
we are
And that
already
was
using it
only
here
one
in terms of
metastasis
the
at
clinical
time of initial
decisions we're making
diagnosis
and
the brain
Caucasian
metastasis
race.
velocity. So for
We
those
also
under
found
4,
that
there
there
tended
tended
to
to
be
be
a
a
plateau
radiosurgery
of new
for
brain
a BMV
metastases at
between
4
4
years.
and 13.
So
we think about
from
either
that data, we asked
SRS
ourselves,
or a clinical
need to
trial
be-
that I'll
does something
share
need
with
to
you in a
change about
second.
surveillance
And if you
imaging?
have a
Or
BMV
do we
over
not have
13,
enough
that's
information
when we
yet?
start to consider whole brain.
So this is a figure showing the cumulative
so,
incidence of distant brain failure
applications
over time.
Of BMV,
And you
so
can see
this
that
is a
at about
study
4
where we're
years, it
actually
does
looking
tend to plateau.
specifically at someone's brain
And there's
metastasis
certainly better
velocity,
outcomes in
and
the
then
group with just the
randomizing them
one
to
brain
different
metastasis.
treatments. So you can get randomized to SRS.
So, big picture,
plus
we've
hippocampal
defined
avoidant
brain metastasis
whole
velocity
brain
for the first
or
time.
N-memantine
And I
or
think that's
SRS
important
alone.
because as we continue to
Dr. Chan,
study
I know
this population, it will be nice
this
for
is
us to
your
be able to
trial. Is there
define
anything in
a
particular
group of
you wanted
people
to share
that doesn't
about it?
that do not have a recurrence
No, I
in their
think
brain
that was a really
metastases
good
for
summary.
years,
And,
specifically
you know,
too,
this is the
versus a
first
different
study
population
looking
that
at
might not have
what's the
recurred but
right
do
thing
not
to do
live
in the
as long.
salvage setting
And that
after
will have
SRS has failed.
applications in the
And
future,
so,
for sure.
you know, anybody out there
I
watching,
also think
please
it's
open the
important
study
to note
and
that there
enroll
is the
patients.
limited recurrence after 4 years. So perhaps if we were to make any changes in imaging, is that the time point that we would
Why
pick,
we did this
perhaps?
present study on the
Certainly more
long-term
to study.
survivors.
And then
So we
the
wanted
other
to
two
assess
key
their
points are,
outcomes. Like I mentioned, is there
one
some sort
brain
of
metastasis
plateau?
being significantly
What should the
associated
follow-up
with a
be?
BMV of 0.
And we also wanted to
Um,
define this
and I think
population of a BMV
it's hard
of
to know
0.
what
So we
what
defined
that
a
signifies. Is
BMV,
this a
but never a
truly
BMV of 0.
oligometastatic
And
patient?
the reason we
Are these
asked this is
biological
because
differences
it's
rather
different.
than we found it when they just had one
with
versus many?
Patients
so more to
who
discover
have
there
no
as
brain
well.
metastases
And
but
I
died
think
2
there are a
months
couple
after
different
initial SRS
hypotheses,
are very
and it's
different
likely
than a patient
multifactorial.
who
Never has a
Caucasian
recurrence
race
and
is
lives
associated
for
with a
3 or 4
BMV of
years.
0.
We
So
know
we
that a
wanted a
large
way to
portion of
define
our
that.
brain metastasis patients have breast cancer. We know that triple negative
And
breast cancers
I
that are more
guess
aggressive
I
are
didn't
more
put that
common in
slide in,
African
my
Americans.
apologies, but
So
a
could that play
BMV
a
of
role?
0 is someone
And then
who
also
has not had a
socioeconomic
recurrence
is
within 2
huge
years
and
after their
can't be
initial
underscored,
SRS.
and certainly another area of future research.
And so
I
on
just wanted
multivariate
to acknowledge
analysis,
before
what
we kind
predicted
of
for
moved on
BMV of
and
0,
opened up the
we
floor.
found 2
Thank
things
you
that were
to you,
significantly
Dr. Dan
associated
McCoe
with
and
that.
Dr.
A
Sheehan, who
BMV
couldn't
of
be
0
here
or no
for this
recurrence
invitation and
within 2
opportunity.
years.
And thank you, of
that
course,
was
to the Journal of
one
Neuro-Oncology
metastasis at time of initial
for
diagnosis
publishing the paper
and Caucasian
and hosting
race.
this webinar.
We
And
also
thank you
found
to Jane,
that there
who's
tended to
also
be a
here today, and
plateau
she
of
helped
new
with
brain
the
metastases
data
at 4
gathering for
years.
this. And she
So
also has her own
from that data, we
paper
asked ourselves,
on
do we
5
need to
year
be-
survivors of
does
brain
something need to
metastases.
change
So,
about surveillance imaging?
Definitely
Or do we not have
a
enough
lot to
information
learn
yet?
there. And of course, thank you for Dr. Chan.
So this
not
is
just for
a
joining,
figure
but
showing
for
the
your
cumulative
mentorship
incidence
for
of distant
going
brain
on
failure
8
over
years now
time.
for me.
And you can
Since I
see
was a
that at
medical
about 4
student,
years, it does
and
tend to
guidance.
plateau.
So thank you. And then to
And
the
there's
rest of our
certainly better outcomes in
co-authors
the,
as well for their input
group
and
with
support
just the
of
one
project.
brain metastasis.
Great job, Claire. I want to thank you guys for contributing this, obviously, to the
Big
journal.
picture,
And then,
we've defined brain
putting together a really
metastasis
nice
velocity for
presentation.
the
I think
first time.
it's a very
And I
unique way
think
of
that's
looking at this
important
with brain met
because
velocity.
as we continue to
And I
study
think
this
it's a testament
population,
kind of
it will be
already to
nice
the
for us to be
relevance of
able
this
to
and that you guys have
define
designed a
a
study
group
based on
of
this, right?
people that doesn't
Moving forward
do
with
not
it
have a
in that
recurrence in
realm.
their brain
And I'm sure we'll reach
metastases
out,
for years, specifically
Michael,
too,
about how to get involved in
versus
that.
a
I'll have
different
my radiation
population
docs
that
look it over as
might
well.
not have recurred but do
I think
not
it makes
live
a ton
as
of
long.
sense. My
And
question
that
for
will
you
have
is,
applications in
how
the
many
future,
patients
for sure.
did you guys look at
I
to
also
compile
think it's
this data?
important to note that
Because
there's
that,
the
you know,
limited
the
recurrence
likelihood
after
of
4
getting to that
years.
4-year
So
mark,
perhaps
I
if we
feel
were
like
to
you're
make any
already
changes in
reducing kind of
imaging, is
your
that the
patient
time point that
population.
we would pick,
And then
perhaps.
having that,
Certainly
measuring
more
that
to
met
study.
velocity in that
And
situation as
then the
well.
other two key points
How
are
many patients are we talking about?
one
And
brain
then on top of
metastasis
that,
being
what
significantly
pathologies are you
associated
seeing
with a
that with?
BMV
Is
of
this
0.
idea that at 4 years,
And I think
the velocity is
it's
low
hard to
because
know
we're dealing with a
what
cancer that doesn't really go to the brain, or are
Is
you
this a
seeing this in the
truly
lung cancers, the melanomas,
oligometasstatic
the breast mets?
patient? Are these biological differences?
Yeah, I think that's a
rather
great
than we
question,
found
the
it when they just had one
generalizability for
versus
sure.
many.
And
So
this
more to discover
was
there
about
as well.
1,100
And I
patients,
think
and
there
then
are
we
a
had
couple
200,
different
hypotheses, and
that
it's likely
survived to 2 years. And
multifactorial.
when
Why
you look
Caucasian
at
race is
the
associated
primary
with a
site,
BMV
it
of
is the
0.
most common.
We
is
know
lung,
that
and
a
then
large
breast
portion of our brain
melanomas.
metastasis patients
So
have
I do
breast cancer.
think it
We know
is
that
generalizable
triple-negative
in
breast
terms of
cancers
our
that are more
normal
aggressive
brain
are more
met
common
patient
in African
population.
Americans.
Yeah, that's
So could
huge
that
then.
play a role?
And then what do you
And
think
then also
happens
socioeconomic is
in the later
huge
time
and,
points that
can't be underscored.
reduces the ability of these
certainly
tumors to
another
go to the brain?
area
I mean,
of
you're talking
future
about
research.
stereotactic radiosurgery. So,
So I
you're
just
talking
wanted
about,
to
focal
acknowledge
lesion.
before we
And we know
kind of
that
moved
even
on
with
and
SRS,
opened
we're
up the
having
floor.
some systemic
Thank
effect,
you
right?
to you, Dr. Dan
Whether it's
McCoe and Dr.
immunologic
Sheehan, who
or
couldn't be here
radiation
for this
based.
invitation and opportunity.
But we also know that these tumors that
and
go
thank
to
you,
the
of
brain
course, to the
have
Journal of
changed genetically
Neuro-Oncology
in some number between
for publishing
40
the
and
paper and
50% or so.
hosting this webinar.
So what
And
happens
thank
at
you
that
to
more
Jane,
extended time
who's
period?
also here
that,
today, and
causes these tumors to
helps
say, no,
with
forget the brain, we're done
data
there.
gathering for this, and she also
Yeah,
has
I
her
think,
own
you know,
paper,
just like our patients,
on
their
5
cancers
are
are brain
heterogeneous as
metastases.
well, and so it could be that
Definitely a
some
lot to
cancers
learn
have
there.
fewer
And of course,
cells
thank you for
that
Dr.
have that
Chan,
tendency or
not
ability to
just
go
for
to the
joining,
brain.
but for
And I
your
think the
mentorship
key
for
that I've already
going on
mentioned
8
as well
years
is
now
that
for
there's
me,
this
since I was a
group
medical
with
student,
one brain met
and
alone,
guidance. So thank you.
that
And then
tends
to the
to
rest
be
of our
truly
co-authors
oligometastatic,
as
and
well for
perhaps
their
we can
input
really
and
get a
support of the
control on
project.
that disease if that was just in
Great
either
job,
small
Claire.
portion of
I want to
their
thank you guys for
overall
contributing
tumor
this, obviously, to the
burden, or
journal, and then
just a small
you
part
know,
of their
putting together a really nice
main
presentation. I think
disease that is
it's a
capable
very
of going to the
unique way of
brain, and then
looking
we
at
can
this with brain
control it
met
with all our
velocity.
different treatment
And
modalities.
I think it's a testament kind of
And
already
one
to the
thing that
relevance of
we
this, and that you guys
found
have designed a
in the
study based
original
on this,
brain
right?
met velocity studies
Moving forward with it in that
was
realm.
that brain
And
met
I'm sure
velocity
we'll
is
reach
kind of
out
a surrogate for systemic
Michael about
control
how
of
to get involved
disease.
in that. I'll have
Right,
my
so when you
radiation
have a
docs
high brain met
look it over as
velocity,
well.
and look at what's going on
I think it makes a ton of
systemically,
sense.
like they
My
tend
question
to
for
be
you is, you know,
failing.
how many patients
having
did
growth
you guys look
elsewhere in
at
the
to
body.
compile this
And
data?
so
Because that, you know,
if
the
you know,
likelihood
in
of
these
getting to that
patients
4-year
in
mark, I feel like you're
Claire's
already
series
reducing kind of your
some of these
patient
other
population.
series that look at long-term
And then
survivors,
having that, you know, measuring that met velocity in that situation as
common
well.
thread that they
You know,
seem to have is the
how many
ability to
patients are we
control the
talking
disease
about? And
outside of
then
the
on
brain,
top of that,
and ultimately
what
that leads to better
pathologies are you
disease
seeing that with?
control. in the
Is
brain.
this idea that
So
at
kind of
4
as a corollary
years,
to that, then, are
the
you
velocity is
seeing
low because we're dealing with a cancer that doesn't really
are you
go
seeing
to the
these
brain, or are you
benefits
seeing
then
this in the
in
lung cancers,
patients, the melanomas,
with
the
targetable alterations, right? Like ALK fusions or
Yeah, I think that's a
EGFR
great
amplifications
question,
in
the
your lung cancer
generalizability
patients?
for sure. And
Or does
this
the
was
patient
about
population really run the gamut?
1,100 patients, and then we had 200,
Honestly,
you know,
and
that survived
I don't want to
2
put you on the
years.
spot, Jane,
And
unless
when you
you're
look
okay.
at the
But Jane
primary site, it is
probably
the most
maybe
common
one of
is
the
lung, and then
best
breast and
people I
melanomas.
know
So
to
I
be
do
able
think
to
it
answer
is
that, because her
generalizable in terms of our
specific
normal brain
research
met
has been in
patient
these
population.
really long-term
Yeah, that's
survivors.
huge then.
And
And
one
then
of the
what do you
factors that
think
she looked at were
happens,
patients who have these targetable
in the later time points that
mutations.
you know reduces
So,
the ability
you
of
know,
these tumors to go to
Jane,
the
do you
brain?
wanna-
I mean,
do you wanna
you're
give us
talking about
your
stereotactic
point of view?
radiosurgery, so you're talking
Yeah,
about
sure. So
you know
we
focal
were able
lesion,
to identify
and we know that
patient
even with
population that lived for
SRS, we're
5
having
years after
some
their first
systemic
SRS.
effect, right?
And we had 98
Whether
patients that
it's
we
you know
found that lived for
immunologic
that duration
or
of time.
radiation based.
And we did look at
But we also know that these
status
tumors that
of
go
a
to the
targeted
brain have
mutation.
changed
And we found that
genetically
only 12
in
of
you
our
know some
98
number
patients had a
between you know
mutation,
40 and
with the
50%
majority
or
being
so.
HER2,
So
followed
what
by
happens at that more
EGFR, and
extended
then
time
ALK.
period
We didn't look at
that
ROS in that
causes these tumors to
patient
say, no, forget the
population.
brain, we're done there?
But a minority of patients did
Yeah,
have
I
those
think,
mutations
you
found.
know, just like our
Yeah, it's actually a
patients, their
fascinating number, huh?
cancers are
Compared to what you would
heterogeneous
expect.
as well.
Yeah,
And
so
so
my
it could
theory
be
on
that some
what is
cancers
going on
have
with some of
fewer
these really
cells that
long-term
have that
survivors, I
tendency
think
or
that
ability to go to
a
the
portion of
brain.
them
And I
is
think the
just
key
very
that I've
indolent
already
biology.
mentioned
Some
as
of them
well
are
is
going to
that
be
there's
exactly what Claire
this
was
group
mentioning,
with
that
one
there
brain
may be
met
some of these
alone
patients who's cured, truly
that tends to
oligometastatic,
be truly
right? But then there are others
oligometastatic, and
that may just
perhaps
have
we can
very
really get a control on that disease if that
slow,
was
indolent
just in either
cancers that
small portion
ultimately
of their
very,
overall
that
tumor
had a very
burden,
slow
or
natural history,
just
end
a
up
small
living
part
for
of
5 years. If you look
their
at some
main
of the rare
disease that is
histologies,
capable of going to
things
the
like
brain, and then we
sarcoma,
can
things
control it with all our
GI and
different treatment
GYN primaries,
modalities.
they were represented. And one thing that we found survivors, the original brain met velocity studies proportion was that as brain met velocity is kind of a surrogate for systemic. It just seems like there are some cancers that are just very slow. Right, so when you have a high brain met velocity, and you look at what's going on systemically in our hands, they tend to be failing.
Very
You
cool.
know, having
Very
growth
interesting.
elsewhere in the body.
So, I
And
mean,
so,
Michael, actually, we have a question from the audience here. We'll tackle that first.
Patients
One of the viewers says, based on your study,
some of these
any
other
suggestions
series
about
that look
how
at
often
long-term
to follow
survivors,
up and
you know,
image patients
a
with the brain met
critical
velocity of 0?
common thread that they seem to have is the ability to control
Yeah, so
the disease outside
well,
of the brain.
Dr. Chan
ultimately
can add in
that
too. I
leads to better
think that,
disease,
the
control.
4-year mark is
So kind of as a
interesting,
corollary
in
to
that
that, then, are you
very few
seeing that
people are
this,
recurring after that
are you
point.
seeing these
So
benefits
I
then in
think a
patients
lot of
with
folks would be
targetable
hesitant
alterations,
to
right? Like
stop
ALK
imaging at
fusions
that
or
point,
EGFR
or
amplifications in your lung cancer
extend it
patients?
out to a year. But
Or
I think it's
does the
something to
patient
keep
population really run the
looking
gamut?
into with some more data.
Honestly, And I don't want to put you on the spot, Jane, unless you're okay. The one thing Jane we probably sort of didn't mention yet is best people the other I know that can happen to be able to answer that because her specific necrosis research. And we are actually really long about to publish. I think the data is embargoed right now. One of the factors that she looked at were patients who have these targeted. We are about to publish mutations. Our series and Jane, I think I could probably say that yes, they do plateau.
Yeah, sure. So we were able to identify a patient population that lived for 5 years after their first SRS. And we had 98 patients that we found that lived for that duration of time. And we did look at status of a targeted mutation. And we found that only 12 of our 98 patients had a mutation, with the majority being HER2, followed by EGFR, and then ALK. We didn't look at ROS in that patient population.
You can certainly
but a minority of patients did have those mutations
once
present.
a year.
Yeah, it's actually a fascinating number, huh? Compared to what you would expect.
And there may be a point where so my theory on what is going on with some of these really long data is such I think we probably need a portion of them validated is just very indolent biology. Some of them are going to be exactly what Claire was mentioning, that there may be some.
Yeah, to be honest with you, I think that's a key component of this, right? And
but then there are others that may just have
what proportion of these patients are you seeing radiation necrosis in a little bit, and then it kind of goes away, and what patients are getting re-opped or not. But at the same time, that's what's kind of I think really elegant about the brain met velocity component, because it's a little bit
things like
in a way naive to that. It's just it's a number over a number, right? And it's an easy thing to calculate, and so I think that's very nice and easy to think about. Proportion. I like to keep these short and sweet. We're at about our 25-minute mark.
Just seems like there are some cancers.
I want to thank you again for contributing to the journal. I think it's a great paper. It's a subject near and dear to my heart. This is something I work on a daily basis. Very interesting. And I'm looking forward to Michael, papers you actually have a question from the audience here. We'll tackle that first. We're looking forward to getting you guys back. One of the viewers says, based on your study, any suggestions about how often to follow up?
Thanks for having us. And definitely anybody out there, please consider enrolling on the BN009 study.
Well, I'm Dr.
Yeah, Michael, why don't you send me some info in the background of that, and we'll reach out. I'll pass it along because we're always looking for stuff.
Very few people are recurring after that point.
Thank you very much.
All right, guys, have a great afternoon. We will see you, I think, next Monday. Let me check my schedule real quick. But otherwise,
extend it out to a year.
This will be uploaded to the Cassini platform soon. And so, thanks again, everyone.
Some more data.
Thank you.
Yeah, I completely agree.
Have a great day.
With Claire. I think that the one thing that we sort of didn't mention yet is the other events that can happen after SRS, so local failure and then radiation necrosis. And we are actually about to publish, I think the data is embargoed right now, so I'm not allowed to say, but we are about to publish our series, and I think I could probably say that yes, they do plateau at some point, events of local failure as well as radiation necrosis. And so ultimately the imaging has to follow not only the event of developing new brain mets, but also the events of potential radiation necrosis as well as local failure. But ultimately, it seems in my mind that there is a point in time where you can certainly space out the imaging to like once a year, and then there may be a point where we maybe even be able to stop. But I think that the data is such where we probably need this to be validated and our next series to be published with regards to local failures and radiation necrosis as well.
Yeah, to be honest with you, I think that's a key component of this, right? And what proportion of these patients are you seeing radiation necrosis in a little bit, and then it kind of goes away, and what patients are getting re-opped or not? But at the same time, that's what's kind of I think really elegant about the brain met velocity component, because it's a little bit in a way naive to that. It's a number over a number, right? And it's a pretty easy thing to calculate. And so I think that's very nice and easy to think about. Team, I like to keep these short and sweet. We're at about our 25-minute mark. I want to thank you again for contributing to the journal. I think it's a great paper. It's a subject near and dear to my heart. This is something I work on a daily basis, without a doubt. And I'm looking forward to the 3 other papers you guys have already alluded to on this talk. So we're looking forward to getting you guys back.
any last comments before we sign off?
Just thank you.
Yeah, thanks for having us. And definitely anybody out there, please consider enrolling on the BN009 study.
Yeah, Michael, why don't you send me some info in the background of that, and we'll reach out. I'll pass it along because we're always looking for stuff. So it seems awesome.
Awesome. Thank you very much.
All right, guys. Have a great afternoon. We will see you, I think, next Monday. Let me check my schedule real quick. But otherwise, this will be uploaded to the Cassini platform soon. And so thanks again, everyone.
Thanks.
Thank you.
Thanks.
Have a great day. Bye.